Hi, it's Dr. Centeno, and today we're going to talk about symptomatic Chiari malformation and CCI, or craniocervical instability. Now, this presentation relies on these three papers. I had read one of these and then was really interested in this topic and kind of dug deeper in the citations and found the other two. And really the concept here is regarding how CCI changes the nature of Chiari. So just so that everyone understands, Chiari malformation is when we see the brainstem or the back of the cerebellum here, and it goes through the big hole in the bottom of the skull, or the foramen magnum. And that can act as like a stopper effect or a stopper on a bottle. Now, the problem that the authors of one of these papers brings up is that we know that there are a lot of people walking around with Chiari 1 malformation who, and that is where this goes down slightly below that hole in the skull, who have no symptoms, and they're just fine, and they'll never probably report symptoms. So what's the difference between people walking around with this who will never have symptoms and those who develop symptoms? And is there a rationale or reason behind that? So again, why do some patients get symptoms? We've got an awful lot of people walking around with Chiari who will never have symptoms, and a small number that have severe symptoms. And the researchers believe that it's the addition of CCI, or craniocervical instability, that makes the difference, that causes patients to have symptoms, meaning they have to have both Chiari and CCI. Having Chiari alone doesn't do it. And this is the mechanism they talk about. That's their diagram off to the left. I tried to simplify it a little bit here. So you've got craniocervical instability. You may or may not have Chiari. Obviously, we're talking about CCI plus Chiari here, but it would also apply to just CCI alone as well. You get mechanical overload of the myodural bridge. I'll talk about what that is. That leads to a stiffer dura. And then you get higher pressure in the CSF, or cerebrospinal fluid, and then eventually injury, or initially irritation, but over long periods of time, nerve injury. So what the heck is the myodural bridge? Because it's an important thing to understand in this conversation and in this research. So these are some diagrams I did a long time ago, but basically the upper neck muscles, rectus, capitis, posterior minor is the biggest one, connect to the covering of the brain and spinal cord, called the dura, through this little guy here called the myodural bridge. So basically this means that the upper neck muscles are jacked into the covering of the brain and spinal cord. Now, normally when you look up, the muscles of the neck pull on that myodural bridge and allow the area back here to stay open. Because ordinarily the dura would kind of kink here as you did this, but it's better that it stays open, so the muscles help keep it open. They connect into this area to keep that area open. Now, if the muscle tendons have problems, or the muscles have problems, and that myodural bridge is damaged, then you tend to see this kind of thing, where the dura infolds and creates a problem here. We've seen this happen actually on flexion extension MRIs, and particularly some of the great MRIs done by Scott Rosa in New York. So this is part of the problem. In addition, that muscle kind of acts as a pump as you move your head around to help pump things through this area, meaning cerebrospinal fluid through this area. Now, What the authors talk about is that if you have this stopper in a bottle effect of the Chiari, as shown here, plus the muscles that are supposed to be keeping this open aren't doing their job, then the whole dura, or the covering of the brain and spinal cord, gets stiff, and this leads to increased pressure. And that increased pressure can cause some significant problems. So you can see here that the dura actually is expanding, and that's normal. And we want that to happen as the cerebrospinal fluid pushes through. And it's the heart that creates that. But when that doesn't happen, and you see stiffness in the dura, then that pressure's got to go someplace, and eventually that pressure goes back towards the nerves and the spinal cord, and that can cause injury to those structures. So how does CCI play a role in all of this stuff? Well, you've got instability at the craniocervical junction, and that activates this myodural bridge because those muscles then try to stabilize the area. That causes spasm, and it causes a dysfunction in how that myodural bridge is operating. In addition, you may have had injuries to the myodural bridge as well due to trauma. All of that increases this intracranial pressure, and that can lead to sort of the headache symptoms that are involved in this phenomenon. And we have different types of instability. Now, we talk quite a bit about atlantoaxial instability, and that's the C1, C2 overhang stuff. But there's also probably instability at the next joint up at C1, C2. So atlantoaxial instability, this is the C1, C2 overhang that we see on DMX. And it could also be an increased Grab-Oaks measurement where the dens comes too far backwards. And there's also lots of other types of measurements, not only to measure C1, C2 instability, but to measure the relationship of the skull to the dens and other things. But the authors of this initial paper talked about, can we measure the risk for instability at C0, C1, and how does that play into this whole syndrome that they're discussing with Chiari? So one of the things these authors talk about is this concept that the C0, C1 joint, when it's normal, which is over here to the right, has this cup-shaped appearance. And that provides stability, right? You can imagine how this part is providing force against the rims of the cup. So if we're talking about front-back stability here for this joint, this is going to be the best one. But some patients, as we go this direction, have a more flattened joint, and there is no cup. So basically, in this one, you can get a lot of sliding. Now, the good news is the ligaments in the neck can help prevent that sliding. But what happens if you injure those ligaments in the upper neck? Well, if you injure those ligaments in the upper neck and you got this kind of joint, you're probably fine or better in that the joint itself is providing some stability. But if you happen to have this kind of joint, that's a problem because it means that your joint doesn't provide intrinsic stability and you're going to get more instability. So these flatter joints can be measured, and they propose, or they looked at a ratio in one of the other papers that was cited that I looked into. And it's a pretty simple ratio to do. It's basically getting into the middle of the joint as best you can on an MRI or CT scan slice, and measuring the length of the joint versus the depth and just dividing those two. A higher number means a normal cup-shaped joint. A low number means a flatter joint. So this is the data that they put together. So they had a control group up here, and these are the folks who have no issues. and they tend to have a higher ratio. And then you've got a case group down here. These are folks who have the problem, which would be craniocervical instability plus Chiari, meaning symptomatic Chiari. And then you've got the middle people who were kind of all over the map. So if we try to look at some metrics here to define normal from abnormal, and this is kind of some data I put together based on their data, it's going to look something like this, that clearly abnormal is going to be less than 0.17. Clearly normal is going to be more than 0.206. And then you've got this middle area where you're not sure if it's normal or abnormal. It's kind of in between. So nice numbers to have, a very easy measurement to do. And I think it's a pretty important finding of these researchers. So how does this new information change how we diagnose and manage craniocervical instability? Well, for certain, we're going to be measuring that ratio of the depth of the C0, C1 joints, because I think it does give another piece of radiographic information or imaging information where we can say, yes, that's not normal and that's consistent with CCI. Obviously, we're looking at lots of things, everything from symptoms to the mechanism of why the CCI is there to what's on the MRI, but it provides another metric. And it also tells us that it may be worth treating those connections in the myodural bridge, because that may be injured in of itself and causing problems because the myodural bridge isn't able to yank on the dura like it should, and that may be leading to this intracranial localized hypertension. So we're definitely going to be adding in much more treatment to the myodural bridge. So again, we come down to what are your options based on this model. Obviously, PICL would be going after and trying to provide stability and tighten down the ligaments that hold the head on. And then obviously, if that doesn't work, surgical fusion to fuse the area. But this is an interesting paper, and I wanted to share this with you because I think it does add another dimension to understanding what's going on with some CCI patients who have Chiari malformation. So thanks so much for watching this, and have a great day.